Hello everyone, I'm back with another topic and it's going to be a very interesting topic, and I believe that most of you guys have not taken it in correctly, and I say this because I've noticed that a lot of you, a good number of you to be more precise, have chosen the wrong option as the correct answer for such type of questions. The topic is called abnormal uterine or uterine bleeding, AUB, and interestingly we have two more terms or names that represent the same condition: abnormal vaginal bleeding, AVB, and dysfunctional uterine bleeding, DUB. All of these terms represent one condition, abnormal uterine bleeding. And yeah, let's get started. The reference I picked for you to discuss is something from three big shots in the industry: Royal Australian and New Zealand College of Radiologists, the Royal Australian and New Zealand College of Obstetrician and Gynecologists, and Cancer Australia. These three names together means that everything you see and hear today is going to be the correct answer for your exam, questions you get in your exam. So let's go ahead and define abnormal vaginal bleeding or abnormal uterine bleeding. But before we do that, we need to know what is the definition of normal periods or normal menstruation. A normal menstrual period or periods are defined as periods which last anywhere between 3 to 6 days, and the amount of bleeding is not more than 80 ml per cycle, and there is no bleeding in between period. This period to that period, there is no bleeding in between. And as opposed to normal, we define abnormal. It's easy: increase in frequency, duration, or amount of blood loss. And please consider that in postmenopausal women, and we'll get to that definition very shortly, any vaginal bleeding is abnormal. I mean any spontaneous vaginal bleeding, not if just trauma, something like that happens and the lady gets some sort of bleeding. It's not called AUB because we have the cause. We have an identifiable cause for that. So for the sake of convenience, I'm going to break down ladies presenting with abnormal uterine bleeding into two categories. The first one is peri and premenopausal women, and the other group is postmenopausal women. We need to define some terms here in order to just see eye to eye. And what I'm talking about, it defines the condition or the status the patient had before she gets this current problem with her periods. It's just jumping on its own. We define premenopausal or premenopause as regular menstrual cycles without any changes in the symptoms of menstruation. Okay, so we want to know that before, like Jane, before you had this problem, how were your periods? Like, were they regular? Any concerns, anything like that? And Jane's like, no, I had regular periods and I didn't notice any changes in the amount of blood. And also I didn't have any symptoms, and all of a sudden I'm getting these heavy periods, like I need to use 10 pads a day, or I'm getting, more days of bleeding and stuff like that. Perimenopausal or perimenopause, we defined it as about or around the menopause. The average length of this stage is 5 years. Periods becomes irregular, and it happens within 5 years around the period time. About the menopause time. So perimenopause, premenopause, and postmenopause. Postmenopausal women are those who has not had any periods in the last 12 months at least. So at least in the past 12 months, they haven't had any periods. We define these ladies, or put these ladies under the category postmenopausal. And I'm saying this because the approach to these two groups is a little bit different. And let's do the approach. forget about this. This is a table or flowchart, better said, from the same guideline I just introduced. So a lady presents in pre or perimenopausal state, like before she started experiencing the symptoms. She was premenopausal or perimenopausal, and she's having a change in bleeding pattern who is concerning to her. So what we need to do as a GP, general practitioner, your level for the purpose of the exam, for the sake of the exam, and what AMC expects of you, is you need to take a history, physical examination, the whole stuff, like everything you need to do before you get to investigations. And then when it comes to investigations, the most important part for you is this upper part. What lies within this box is going to be very important, and probably the most next step in management, or the most important investigation to consider first, is within this box. And you know where the problem arises? It arises not here, not at the lower part, because here we have just if, thens. You know what to do. If you're in this box, you go to this, and we have two more conditions. If this, then this. If this, then this. And it's easy. The problem is in this box. So we have this patient, and they have mentioned we need to exclude pregnancy, exclude cervical pathology, full blood count, and if required, thyroid function test or coagulation profile. So all together. In real world, what you can do is just grab a piece of paper or order whatever test you want. You want to send the lady for a urine sample to test her for pregnancy. You can order full blood examination, or you can just do a cervical examination, a pelvic examination, and get a swab and send it for pathology. But for the exam, this is a different story, because you have to choose just one option. And which option would it be? To exclude pregnancy, full blood count, or cervical pathology? Which one? This is where the problem starts to appear. Okay, I'm going to break it down for you. Every patient, every lady patient in her peri or premenopausal stage, at these stages, who presents with abnormal uterine bleeding, the first thing you need to do is just to exclude pregnancy. This is always the correct option if the scenario is about a lady of peri or premenopausal age who has presented with abnormal uterine bleeding. And it's very important to consider. The patient denies and looks at you like a retarded doctor. Doctor, I had my period like just last week, and I'm using condoms. How on earth I could be pregnant? And you're like, patience, I know where you're coming from. I really understand your concern and why you're wondering. I'm ordering a pregnancy test, but believe me, I need to do that first of all, because you might be pregnant without you even knowing, and this bleeding is happening because you're having a miscarriage. Or second, I need to cover my back. It's very important to document, to test every lady patient presenting with abnormal uterine bleeding for pregnancy, and document the results very thoroughly and carefully in your notes. What comes next? So say, let's get back here. We have this Sarah, 26 years old, presenting to your GP practice with complaint of heavy periods for the past 3 months. She says that she has been using more pads and also sees clots. Oh my God, so she's having a lot of bleeding, increased amount of bleeding. It's just changing slides for itself. I don't know what's happening with my PowerPoint today. And she denies abdominal pain and discomfort. So for now, we, not that, miscarriage or ectopic pregnancy is unlikely, but they're least likely because we don't have any abdominal pain or discomfort. She's sexually active in a stable relationship, but denies pregnancy. She did her first CST or cervical screening test last year at 25 with normal results. Which one of the following is the most appropriate next step in management? And you already know the answer. What is the most appropriate next step in management? I believe it's going to be a pregnancy test, despite the fact that she denies pregnancy. Got that? Okay. What comes second? Second, after you excluded pregnancy, or if exclusion of pregnancy is not an option, the second most important option to consider is a full blood count or full blood examination. And we do that not only to exclude anemia, but also to check the platelet status, because low platelets might be the cause of this heavy bleeding. Even if the patient's presented with the first time of bleeding and just like she noticed heavy bleeding for the past 2 days and there is no chance that she's anemic, you still want to do the full blood examination to check everything. Anemia, hemoglobin, hematocrit, red cell count, and also platelet count. It's very important. So, again, I'm going to repeat that again and again and again until it becomes second nature for you. For every patient presenting with AUB who is premenopausal or perimenopausal, the first thing we want to do is to exclude pregnancy. Second, we need to do full blood examination to make sure she's not anemic or the platelet count is normal. So what about thyroid function test and coagulation profile? Look, we don't normally routinely do these two tests for every patient presenting with AUB unless it's clinically indicated. And I mean that the patient presents to you and she's having AUB and she's also having symptoms or physical findings of thyroid disease like hyper or hypothyroidism or whatever thyroid disease for that matter. In that case, you will order a TSH as screening test for thyroid disease as well. Like the patient's doctor, recently I've been more sleepy, I can't tolerate cold weather and blah blah blah, so you suspect she might have hypothyroidism. So and the hypothyroidism very well could be the reason for heavy periods. Like I just want to teach you something. Thyroid disease can result in period abnormalities. Hyper or hypothyroidism could cause both heavy period or menorrhagia or metrorrhagia, meaning menorrhagia, or what was the other term? Amenorrhea, like scattered periods or things like that. But for the purpose of convenience, please learn this. Hypothyroidism, hyperperiods. Like if you have hypothyroidism, the periods are going to be probably more heavier. And if we have hyperthyroidism, the periods are going to be just decreased or scattered. Okay, so like I said, thyroid function test is only indicated if clinical presentation suggests thyroid disease. What about coagulation profile? Like thyroid disease, we just don't order that for every patient presenting with AUB. We only do that if the patient has a condition in history or physical examination that suggests coagulation disorder or bleeding disorder. Like for example, she says, "Doctor, I've been seeing more bruises on my skin recently," or when I get a nosebleed, oh, I have a ghost in my room and the ghost, lovely ghost, is moving my laser pointer. Oh my God. I'm scared. Okay. Or I have, my sister just gets nosebleeds so easily, and this is why you want to consider coagulation disorders as a cause of these heavy periods. Okay, we're done with this upper part. No, we're not done yet. A very important thing, a very confusing thing for you guys, because I've seen questions like this lady patient's been having heavy periods or whatever menstrual abnormalities, and like for example postcoital bleeding or whatever, and also she had a pap smear done 12 months ago, 6 months ago, 3 months ago, 2 years ago, 5 years ago with normal results, and repeating the pap smear is one of the options. This becomes a trouble if you don't know how to approach such cases. Okay, while we are on the upper part, when do we want to do pap smear or cervical screening test? Let's get to that. This part. When to consider pap or cervical screening test in pre or perimenopausal women with AUB. I'm talking only and only about peri and premenopausal ladies with AUB. We consider pap smear if there is postcoital bleeding in the history, like the ladies like, doctor, I noticed some blood after I had sex with my husband or my partner. Or if there is unexplained intermenstrual bleeding in the history. And what do I mean by unexplained? The patient says, doctor, I have spotting, bleeding in between my periods. And you're like, are you taking any hormones? And the patient's like, yes, doctor, I have implanted or have Mirena. Or I've just started, OCPs. So the reason is obvious. The reason is clear. This patient is getting intermenstrual bleeding because she's on progesterone. Or the patient's like, doctor, I have gained some weight. And also I'm having more hair on my chin. And I'm getting just heavier. So you think PCOS, polycystic ovarian syndrome, and maybe this patient is not having ovulatory cycles. So this is why she's getting erratic bleeding or spotting. So we have an explanation for the intermenstrual bleeding or spotting. So in that case, we wouldn't call it unexplained. But if there is no explanation for this intermenstrual bleeding, we want to repeat the pap smear or consider pap smear. Better said. Okay, when do we order the pap smear? If indicated from above, we order pap smear if there is no normal result in the past 3 to 6 months. I mean that if the patient had a pap smear done 12 months ago and the results were normal, and she's having postcoital bleeding or unexplained intermenstrual bleeding now, regardless of the results, that was normal, we want to repeat the pap smear or CST again. This is very important to understand and consider. So we're done. The upper part is done. Now comes the next part. After we did our initial investigations, based on what we did, we excluded pregnancy, we excluded full blood count, we did a full blood examination, and we also just considered whether we need a pap smear cervical screening test, and we've ordered all of those. We're done with those. We come to this line. If the patient's low risk, there is no anemia. Low risk, the risk means the risk of cancer, like more like endometrial cancer. There is no risk factor in the history. The patient's low risk. There is no anemia from the full blood examination. And this is the first episode of irregular bleeding. We just consider conservative treatment of abnormal vaginal bleeding and monitoring. But if bleeding continues, we request transvaginal ultrasound or TVUS, and we ask the radiologist to report to have endometrial thickness included as well. It's very important. If there is history of chronic anovulation and or PCOS, go straight to transvaginal ultrasound. If there is increased risk like anemia, persistent erratic menstrual bleeding, or persistent heavy bleeding, what we want to do is to request transvaginal ultrasound. So the things you need to consider for your exam as correct options that you need to think about is exclusion of pregnancy, full blood examination, pap smear, and when it comes to imaging, transvaginal ultrasound. If the patient has some sort of contraindication to transvaginal ultrasound, like for example she's a virgin, we just consider transabdominal ultrasound instead of transvaginal ultrasound, but the accuracy is decreased. Okay, and the rest of the flowchart for now is not of our concern for this topic, but we can discuss some of these options later on. Now we've concluded the investigations we need to consider for pre- and perimenopausal women who present with AUB. To put it in a nutshell, we exclude pregnancy, we do a full blood examination, and we consider doing a pap smear if the patient's presented with unexplained intermenstrual bleeding or postcoital bleeding, and we just do those tests, and we request a transvaginal ultrasound or ultrasound. Now we're going to talk about postmenopausal women. And who are postmenopausal women? Again, think about that. Women whose periods stopped at least 12 months ago. In such women, any sort of spontaneous bleeding is abnormal, regardless. What do we do about AUB in postmenopausal women? And we have this problem here. Exclude cervical pathology. When do we do that? Always. When to consider PAP or CST this is not perimenopausal. This is only, I'm going to cross it out, in postmenopausal women with AUB. Always. If last test done earlier than the past 3 to 6 months. Again, like this lady's presented 56, 62, 75 has presented with abnormal uterine bleeding, and she did a pap smear like 2 months ago with normal results. We don't want to repeat that, but if it's earlier than 3 months, 3 to 6 months, we want to repeat that. That's for sure. Don't forget about that. Okay, what about other investigation? Full blood count, FPE. For peri and premenopausal ladies, we just do the full blood examination for every patient. For postmenopausal women, on the other hand, well, we only do that if it's clinically indicated, like if we suspect anemia, or whether it's based on the history or physical findings of pallor, or like pale conjunctiva, just palpitations, fatigue, stuff like that. So obviously there is no exclusion of pregnancy here unless you're absolutely out of your mind. We don't even think about exclusion of pregnancy in such ladies. We want to exclude cervical pathology. This is a must, and maybe we want to consider full blood examination if clinically indicated. And when it comes to further investigation, we request a transvaginal ultrasound. And we ask the report to have endometrial thickness included as well. Very important again. But there is something here. It's very unlikely that you get this in your exam, but just to let you know, when we have this lady presenting with abnormal uterine bleeding, AUB, and he is postmenopausal, we ask her a question. By any chances, are you taking tamoxifen for breast cancer or whatever reason? And the lady's no. So we do want to refer this lady directly to a gynecologist. Tamoxifen, long-term use of tamoxifen means endometrial hyperplasia, and endometrial hyperplasia means increased risk of cancer. We wouldn't waste our time, but before referral, we still might consider a transvaginal ultrasound to be included in the referral documents. All the women with postmenopausal bleeding request transvaginal ultrasound, TVUS. It's vital. It's very important. So we have, again, It's very important, guys. Please pay full attention to that. We have this upper part, investigations, exclusion of pregnancy, full body examination, thyroid and coagulation profile if indicated, and when it comes to imaging, transvaginal ultrasound. For postmenopausal lady, what we do, we definitely want to do a pap smear if there is no available normal results from the past 3 to 6 months. We repeat the pap smear, or we order a pap smear, and also we arrange for a transvaginal ultrasound. As easy as that. Okay, this is another great slide by National Cervical Screening Program, Health Department, and Cancer Council. Forget about this part. We're not going to talk about this. For the investigation, full investigation, you might want to use the earlier slides we talked about. For every postmenopausal bleeding, spontaneous bleeding happening in ladies of menopausal stage, we always order a co-test. Co-test is the same thing we refer to as CST, or cervical screening test. Nowadays, what we do is just we take a liquid sample and we send it to the pathology. The pathology assesses the sample for the presence or absence of human papillomavirus and its types, and also it checks the liquid-based sample for the presence of abnormal cells like HSIL, LSIL, or inflammatory cells or cancer cells. And for this part, postmenopausal bleeding, we do the test and we refer to gynecologists regardless of the test results. So the results are negative, we refer. The test results are positive, we still refer. So why do we do the test result if the results are not going to impact the referral? Because specialist is going to need the test results for further assessment and planning the management. And also for unexplained intermenstrual bleeding, again, same thing, same process. We order co-test and we refer regardless of the test results. What about the postcoital bleeding? It's a little bit different here. We order the co-test and we wait for the results. If the results are negative and the postcoital bleeding was just one single time, and on physical examination the cervix is clinically normal, we consider, for this pathway here, we consider conservative management, and we advise the patient to keep an eye on her symptoms. If they come back, she comes back. Okay? But if the postcoital bleeding is happening frequently, or it's recurrent or persistent, we refer. So postcoital bleeding, persistent, recurrence, even if the test result is negative, we refer. If it's positive, we refer. Clear? Okay. This question, please pay full attention to that. Jane, 20 years old, presents to GP practice because she's concerned about her last period, which stopped 5 days ago. Unlike her other periods, this last one took 10 days. Her periods are normally 4 to 5 days. With significant amount of bleeding, she had to use more pads and also saw clots. This indicates heavy bleeding. Her periods were otherwise normal, happening every 30 to 32 days. She denies abdominal pain or discomfort for now, which is a relief because we are less likely to think issues such as miscarriage or ectopic pregnancy. They're not unlikely, but lack of these symptoms make them less likely. And is otherwise healthy. Otherwise healthy means she's not having any bleeding disorder, easy bruising, like thyroid symptoms, thyroid disease symptoms, hyperthyroidism. She's sexually active and in a stable relationship, but denies pregnancy. Does it affect our management? No. The patient denies pregnancy, like I told you before. Yes, you're right, you're not pregnant. But I need to do the pregnancy test just for the record, and I'm going to do that. I need to do that for every patient presenting with your symptoms.
One more thing here, that she's not done any CST, cervical screening test so far. And you already know that in Australia, every lady has to be started on a cervical screening program at the age of 25. She's 28 years old, so she's already 3 years late for her first test. A novice pregnancy test is negative. Which one of the following is the most appropriate next step in management? Let's cross out irrelevant options for now. She's otherwise healthy. No hypo or hyperthyroidism. Thyroid function tests, not required. Coagulation profile, not required. What about these three options? Transvaginal ultrasound? No. You remember the earlier slides? First episode, no risk factors, no transvaginal ultrasound. We ask the patient to come back if it happens again. First episode, no risk factor. Second episode, it's called recurrence, so we might want to consider, or we have to consider transvaginal ultrasound. Do we recommend CST as she's overdue for that? Absolutely. We have to tell her that, look, Jane, this is National Cervical Screening Program, and this has this and that benefits for you, so you might want to consider that, and I highly recommend that you consider that. But again, this is not a priority. These patients, we can't just, ask her to come back for another discussion or for another, visit, and we can advise that later on. It's not vital to do it right now, right away, today. But for her, full blood examination is a must and the correct option here. You remember every lady presenting with AUB who is at pre or perimenopausal state, they need to get a full blood examination done to check for not only anemia but also a platelet counts. Okay, I hope it's clear. Next slide. Let's talk Indra, 52 years old, presents to your GP practice because she has been experiencing bothersome vaginal bleeding and spotting for the past 3 months. The bleeding is scanty, small amount, has never been heavy, but is annoyingly unpredictable, scatter bleeding, unpredictable bleeding. She's still having her periods, but they're becoming more and more infrequent and irregular, and she's already 52, so probably she's at perimenopausal stage, around menopause. She's just approaching menopause. Where were we? She denies symptoms of anemia and thyroid disease. She lives with her husband and is sexually active and sometimes experiences a small amount of bleeding after intercourse. Now, ding, 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 we have something very important here. She's having postcoital bleeding, right? Was that? Experience a small amount of bleeding after intercourse. A very important thing, a very important piece of information. Red flag. Her last cervical screening test was 18 months ago with normal results. Do we care about that? Not at all, because we care about a normal test CST result if it's been done in the past 3 to 6 months, not any later from 6 months. Sorry, earlier than 6 months. So this is another important part of the scenario. When you ask her if there are any chances she's pregnant, she looks at you like she has seen the most retarded person in the world. But you explain kindly, and that's your job, that these are the questions you need to ask from any patient with similar symptoms. And just to top the awkwardness, you send her to the toilet to get a urine sample for an office pregnancy test that, thank God, turns out negative. You remember to ask if she has anything like skin darkening under armpits, breast, or on her neck. Acanthosis nigricans, any excess hair growth, or any recent weight gain. You're asking about the symptoms of polycystic ovarian syndrome. She says yes to all. So she might have polycystic ovarian syndrome as well, which very well justifies the unpredictable scattered bleeding. So do we want to order pap smear? Yes, because apart from that, although she's having, the erratic bleeding could be explained by the PCOS, but don't forget, she's having postcoital bleeding. Every lady, peri or postmenopausal with postcoital bleeding, we send for, or better said, every lady with postcoital bleeding, we want to check pap smear if we don't have a normal pap smear from 6 months ago. Anything, from, later than 6 months ago, not earlier than 6 months ago. Okay. You explain your doubts and the differentials to her and arrange for the transvaginal ultrasound. Now you have to think of all other things you need to do. What are those? And I'll tell you what, there are more than one correct option for this question. And I want you to prioritize your choices. Perimenopausal, vaginal bleeding, full blood examination after exclusion of pregnancy. First one. Do we want to repeat CVS? Absolutely. This is another must. FSH and LH to see if she's menopausal. Look, we might consider hormonal assessments, but for the sake of making a diagnosis of menopause, never. Menopause is a clinical diagnosis. Coagulation profile? No, because she denies any bleeding, any symptoms, and there is no mention of such concern in the scenario. Check her testosterone level? Yes, why not? She's having symptoms of polycystic ovarian syndrome. We do the transvaginal ultrasound. We may or may not find, polycystic ovaries, which can be a diagnostic criterion. The other thing we need to have in order to make a certain diagnosis is elevated testosterone levels. So this is an important thing to do. What about FSH, LH, progesterone, estrogen for the sake of polycystic ovarian syndrome? Yeah, order those, but the only thing we're going to need is elevated testosterone level. Estradiol, chlamydia, or gonorrhea? Yes, why not? This could be a good option as well, but you need to be careful with that. This lady is in stable relationship. You might want to approach her and more cautiously and politely. You need to explain to her that, look, Indra, I know you might think it's not necessary, but one of the causes of postcoital bleeding could be cervicitis, which means the inflammation of your cervix, the outer part of your womb that opens into your vagina. And for that, do you want me to order to take a strap and send to pathology for being on the safe side to make sure that you don't have any chlamydia or gonorrhea infection? And you have to explain to the patient, what if the test result is positive, what if the test result is negative? This is called pre-test counseling, and you have to do that for every patient. We have some similar question. This patient is just about to undergo HIV testing. What we need to do is just we have to counsel her before we send the patient, or him before we send the patient for the testing. Genetic testing, yes, we have to counsel it. We have to do the pre-test counseling for what test that you're going to send the patient for. You have to do the counseling. It's called pre-test counseling, and do that always. It's a very important thing to do, to consider all the time. Okay, so for this question, full blood examination, repeating the CVS, checking testosterone level, and probably a strap for chlamydia and gonorrhea are the way to go. Okay, that's it for today. I hope that you get everything clearly and beautifully, but remember, if you have any doubts, any concerns, if you want more clarification or explanation for any of the things we discussed today, please don't forget to drop a comment in the comment sections below. And also, if you find any value in this video, please give it a big thumb up like this, like button, and also subscribe to the channel to get notified when we post another video. We're going to have a lot of videos for you. Okay, guys, that was it for today, and enjoy the rest of your time. Bye.